Welcome back to another episode of the Braun Performance and Rehab Podcast, powered by ISOFIT and Firefly Recovery. ISOFIT is my go-to for all things isometric strength training. For more on ISOFIT, be sure to check out isofit.com. Episodes like this are made possible by Firefly, the official recovery provider of the Braun Performance and Rehab Podcast. For more on Firefly, be sure to check out recoveryfirefly.com. This episode is powered by Dr. Ray Gorman, founder of Engage Movement. Learn how to boost your income without relying on sessions. Get a free training on the blended practice model by following at Ray Gorman DPT on Instagram. Joining me today on the podcast is Pratik Soni. Pratik is a doctor of chiropractics and a current physical therapy student. This guy does it all, and we're going to dive into spinal manipulation in detail today. What it is, how it works, different techniques, why we might do it, why might we choose not to do it, and so much more. Pratik clearly knows a lot about this topic, and I'm super appreciative of his time. Highly recommend you check him out and check out the Physiolab CEU, which is where Pratik hosts spinal manipulation courses with another individual, Eric Jord, as well. So if you're interested in learning more about this stuff, highly recommend you check them out. Enjoy. Pratik, welcome to the podcast, man. I'm super excited to work with you today, and shout out to our many mutual connections that have helped get us here, Marin and many other people that way. For people who aren't familiar with you and all the incredible stuff you're doing, whether that be on the restaurant side of things, the chiropractic side of things, soon the PT side of things, the education side of things. I mean, you're a man of many talents, I give you that, but would you mind filling people in a little bit about who you are and all the great things that you've been doing?
Yeah, so thanks for having me. I'm excited for what we're about to dive into. I'd like to think of myself as just an average person. I just like to work hard and try to do many things. But, like you said, a current chiropractor. I graduated in 2019 from Parker. I've been doing that for 5 years with my own office, back in Motion Chiropractic. And so I've learned a lot of clinical stuff. I've actually also had the opportunity to work with, two pro teams, the Dallas Wings, WNBA, as well as the lacrosse team, the Panther City Lacrosse Club. And so I got to see that side team aspect of integrating with different providers, all that. And then pretty recently, about 2 years ago, I decided to branch out a little bit and open a restaurant. Um,
Because
just
why not?
yeah, just a little side gig. Something for me and my parents to keep our minds busy on. And then my most recent endeavor, as if I didn't have enough, was I decided to go back to school for physical therapy. So currently in South College in Atlanta, doing that program. I'm about half a year in, and we'll graduate in 2026, summer 2026.
That's awesome, man. I mean, like we said, you're a man of many talents and you're doing so many different things. And I think it's so exciting to see someone as great and just overall as passionate as you are entering the space of physical therapy. But one of the things I've noticed from a physical therapy side of things is there's this increased reliance or use of technology in the space. And sometimes that's a great thing. And sometimes there's some issues with it, right? Like what happens when the Wi-Fi goes out or the tablet didn't get charged or whatever it is that way. And ultimately, I think one of the most powerful and impactful things that a clinician has is their own two hands and knowing how to use them effectively and how to palpate and how to intervene and make a change and make a difference in a matter of sometimes just seconds by just using your hands. And I know some people even express concerns with the technology side about, what happens if AI is coming for my job? And it's like, well, plain and simple, AI cannot replace your own two physical hands and the things that they can do for people. And I think that essentially the whole space of physical therapy should be looking at manual therapy as one of the hallmark things, not the only thing. Obviously, exercise and all these other things are very, very important. And I certainly do more exercise than manual therapy. But for a lot of my patients, it's the things that I do with my own two hands that really get them to understand the value that we can provide for them. And I think that clinicians really, in today's day and age more than ever, need to be super skilled with their hands if they want to make a difference with the patients that they're treating, regardless of who they're treating, older adult, athlete, whatever. You just really have to be freaking good with your hands, man.
Yeah, definitely. I think a lot of times is we've gotten all this cool stuff coming out, 3D scanning and, footprints and, all A to Z, you've got it all coming out. And so I think sometimes we get caught up into those relying on those things versus what you have in your brain versus relying on technology. So yeah, the biggest thing, the most powerful thing I think we've talked about in PT school already was, your own two hands can be healing hands. And there's actually some research done on that where when you physically touch a patient, you're actually, doing some kind of, I don't know what they call it, some energy transfer or something like that, where you actually feel like the patient is actually feel like they're healing. So those are the most three important things, including your brain.
So you actually have to put hands on your patient physically in order for them to get better. It's a crazy
Crazy concept.
concept. Yeah, I know. And one of the things that I find a lot of benefit from when I'm working with patients, and it's not the only thing that I do, believe me, I dry needle. I mostly dry needle from a soft tissue standpoint at this point. I'll still do cupping and scraping on occasion, but I'm very, very heavy with the needle. But outside of that, especially for joint related things, I'm very heavy on manipulation, spinal manipulation, extremity manipulation. It's very time effective and it gets people the results that they're after. But I find a lot of times I spend more time explaining what I'm going to be doing than actually doing it because there's so many misconceptions around spinal manipulation, other types of manipulation in the extremities and so on that way. So for people who have, obviously heard the term or maybe seen those trendy TikTok videos, I'm still waiting for you to post one, by the way. I can't wait to see the Pratik signature spinal manipulation TikTok pop up. But for
Coming.
people who see that stuff but are like, what the heck is going on here? Would you mind filling me in a little bit about the kind of theory and application and thoughts behind spinal manipulation and extremity manipulation that way?
There's a couple of different theories out there, and I started kind of diving into this once I got into PT school because hearing the chiropractic side of the theory of you've probably heard of it, the theory of subluxation, where we believe that there's a bone that's partially out of place, and what we do as chiropractors is we realign that vertebral segment with specific adjustments. We call it adjustments. I know it's manipulation in the other worlds, but we do a specific adjustment to realign, quote unquote, that specific area. There's other theories out there. And the biggest thing that I guess the general population, if it's their first time receiving a spinal manipulation, is, what is that sound? What is that crack? Why does that happen? And so I know there's some debate about that, recently about is it actually a gas formation or is it gas releasing, or is it gas reabsorbing and then releasing? There's a couple of different articles and literature about that, but essentially it has to do something with along those lines of gas being released or being formed. And so that's the biggest, I guess, scary point that the general population has. Now, some of the adjusters have manipulators have a weird, I guess, not a weird, but a technique specifically where you put individuals in different angles. And so there are different techniques out there, but the most important thing is to relay to your patient what you're doing, but more importantly, why you're doing it. Are we doing it to, decrease pain? Are we doing it to increase motion? But not only that is making sure you're not telling the patient the wrong thing. There's a lot of misconceptions on what manipulations actually do, and I'm sure we'll dive into a little bit of that. But making sure that we're providing the why behind why we're doing a manipulation. Is it right for the patient? Because sometimes it's not right for the patient. Sometimes, the irritability level is way too high. Sometimes they need more strengthening, like you mentioned, more rehab and exercise. But yeah, those are the main biggest points as to why we're doing this manipulation and comforting the patient of how it's going to happen as well.
Yeah, and it's interesting because I find a lot of the time when I talk with patients about it, they all know someone who's had a bad experience or bad story that's related to manipulation somehow in some way.
Yeah.
And it's sometimes just kind of a matter of, pumping the brakes on that a little bit and easing those fears and kind of getting them to realize, like, hey, look, this is a very safe intervention. Earlier before we got on, we were talking about different modes of travel and what's the safest and so on that way. And to me, spinal manipulation done by a competent provider is an extremely safe intervention. But you have to understand what you're doing and why you're doing it, to your point. If you're just going to go around manipulating everyone just because you feel like it, then obviously you're going to be asking for trouble at some point. Take for example, hypermobile patients, right? If you've got someone who's all the way to the far end of the hypermobility spectrum, I'm talking like, 90 plus degrees, passive hip IR, and just super, super bendy, basically a contortionist, and you go and you start doing a ton of upper cervical manips on them, that might not be the best idea there, Chief. But, who am I to judge? I'm just the PT. I don't have quite the level of spinal manipulation experience as you do, Pratik. But, with that in mind, what are kind of the like general indications, contraindications that you look for from a manipulation standpoint? What makes you say, you know what, yes, this is going to be a great intervention for this person, versus, you know what, I need to pump the brakes. This person is not the right fit for it.
The first and foremost thing is you have to do a very thorough exam. You have to rule out all the contraindications. I know the biggest thing that's happening recently in the past few years is the whole correlation between neck manipulation and stroke. Most of the time that happens because the practitioner does not do a very thorough exam of the current history as well as a previous history of the patient. If there are signs that are leading the practitioner to thinking that there might be a smallest chance of any kind of cardiovascular issue, you should pump the brakes on that. And we should always put a prevalence on that, because sometimes in the world of manipulation, like you said, we just go around and manipulate everyone. Hey, let me practice on you. Let me manip, or let me do an adjustment. And so sometimes we have to take it slow, because it is a cool and trendy thing, right? Going around and showing off that you know how to properly do a manipulation. And so that's the first thing is, foremost, you should always do a thorough examination evaluation. A lot of the other indications to do a spinal manipulation is the biggest and the most foremost thing is pain. You look at the current history or your current research of what happens during a manipulation is, we're physically changing some of the brain chemistry, the cortical thickness of the brain that's been measured. You're decreasing substance P in the saliva that was measured. And you're doing all these things to decrease pain sensitivity. The neural inputs going into the brain changes the motor outputs, right? So you're doing things to decrease pain. So that's one of the most important ways that we can affect the patient's pain, the irritability levels. On top of that, a lot of individuals like to think that restrictions and range of motion decrease is another indicator. It can be. However, if they're having pain into that end range of motion, maybe it's not a good idea. Maybe doing some joint mobilizations away from that range and easing into that range is a better way to start. And so those are the few indicators that I've seen works best in terms of doing a manipulation and going around with that. But like you said, we also have to look out for hypermobility patients. I've had a patient once come in, and she's been saying that she's been getting adjustments for years. And so we kind of conducted the Baton scale, where you check the hypermobility of her fingers and her elbows and everything. And she kind of knocked every single one of those out of the park. And she told me that she was never getting better from adjustments. And I was kind of like the first one to tell her, well, maybe adjustments is not right for you. Because if you're always feeling pain, discomfort, the day after, 2 days after an adjustment or a manipulation, maybe that's not right for you. We need to look into more doing a strengthening stability kind of program instead. And so it's not for everyone. It can be for a lot of people, but we just have to make sure we rule out the contraindications and make sure the patient is actually indicative of doing a manipulation.
Quick break, because if you're a rehab professional sick of burnout, this could be your answer. Engage Movement's blended practice model is a proven system built by Dr. Ray Gorman, a PT who walked away from the 55-hour-a-week grind and built a blended practice model that doubled his income while working less than 25 hours a week, and he didn't have to rely on the traditional way of selling sessions to do so. It's all about blending remote and in-person services, stacking monthly recurring revenue, and building a business that finally supports your life, not the other way around. This model isn't just theory. Real providers, including myself, are creating lives of freedom and flexibility without being tied to their schedule. And as a listener, you get free access to the complete training. DM my name, Dan, to @RayGormanDPT on Instagram and receive your free breakdown on the model. Yeah, I think that's a great point. And to your point about, the end range and that sort of thing that way, one of the biggest things that took me far longer than I wish it did to learn about manual therapy and spine manipulation is your patient has no idea what the technique is and they have no idea how to do it. So I will take people to that end range and I'll kind of move them around there a little bit and just kind of get a feel for what that end range feels like, right? I'll especially do this if I'm doing cervical that way, is I want to feel that kind of lock before I do that quick little twist kind of movement there. I'm sure you've got a technical term for it. I just call it whatever this hand motion is.
I think
But
the rotary thrust
the
is what.
rotary thrust. I like that. That's real technical. I like that a lot. But I kind of get a feel for what it feels like. When does it lock? And I'll kind of adjust my position a little bit with that as well. Sometimes I actually bend people a little bit more. Sometimes it's more of like a side bend, side glide combo. Sometimes it's more rotational, like a different angle that I'm going to twist from or thrust from, if you will, that way. But I just kind of get them there and get a feel for it before I actually do anything, just to kind of like reassure myself, like, yes, this is the feel that I want. Because I think, there's no point in doing the technique if you're not getting the end feel that you're after, right? And to that point as well, I've had some people come in and they'll be knocking on my door requesting me to do a manipulation on them. And then I start moving their neck around and I see just how mobile they are there. And I kind of put their head down and I'm like, I'm not going to do this. I might do something else, but I'm not going to do this because it just doesn't feel right. And I think that that kind of like gut instinct, if you will, and just taking a minute to pause and kind of assess what you're feeling in the motion, even if you feel like other things have pointed towards spine manipulation, even if your patients are asking for it, sometimes it's just not the right thing. And it's better to just hold off instead of, put them through that and then run the risk of what if something goes wrong. Again, it's extremely rare, but I still like that track record of nothing going wrong.
Yeah, and it's also to that point, it's also important to, like I said, to make sure your patient actually needs it. A lot of times you can have your own office, and this is where there's a little bit of a controversy that's happening is you can have someone that's fantastic at manipulations and have their own office, and you've got people walking in the door, hey, I want a manipulation, I want this, I want this. And on one side, I've had providers tell me that, you know, they want this, I'm collecting money for it, why not provide it? And so there's this huge controversy of kind of just offering the service just to bill it and collect it, the money, versus doing something what's actually right.
The other piece to that as well is, I might choose to do a manip on someone requesting it, but it might be in a different region than they were initially thinking. And going back to your point on the eval and examination that way, I think that concept of regional interdependence comes in, right? Maybe someone's coming in and seeing us for neck pain, but in reality, their neck moves fine. It's actually, they have like no thoracic spine movement. Or, on the flip side, maybe they're coming in with lower back pain and their lumbar spine moves just fine. But again, T spine is not moving whatsoever, right? Sometimes we actually have to look in other regions instead of the ones that they're actually coming in for. They'll say, well, I just want you to manip my lower back, make the pain go away. And it's like, I could do that, but if it's more of a mechanical construct that I'm thinking of, right, a biomechanical model, then maybe I'd be better served intervening elsewhere, not necessarily just the site of pain. If you're thinking more along the neurophysiological side of things, maybe you're good to do a manip in that painful area. And maybe it calms things down and opens up a window of decreased pain for you to do other things to move the needle forward. And I'm perfectly okay with that. But I think it ultimately comes back to what is your exam telling you? And are you pointing towards that biomechanical consideration or the neurophysiological consideration?
You bring up a good point because the whole concept of regional interdependence is huge in the manipulation world. You look at some studies done with individuals with headaches. There's a whole trial that was done, and then I'm pretty sure there's a few systematic reviews that I've read where you take individuals with headaches and you only manipulate their thoracic spine, and you look at how improved they've got with their headaches, their pain relief, their pain scale, and there was a pretty significant correlation with the amount of decrease their headaches have gotten versus if they actually did a neck manipulation or a thoracic manipulation. So there was actual benefits just doing a thoracic manipulation in those studies. And a lot of times, like I mentioned from the very beginning, the chiropractic model believes in this subluxation theory where we believe a specific adjustment needs to be given to a specific vertebrae to help decrease pain, whatever may be going on. But in theory, there's been studies done where sometimes if we even try to go palpate C7 between two different providers, we're completely off. And so, you may be palpating C5 and I may be palpating C6. So if we're both providing manipulations to a specific adjustment, we're both doing it to different levels. And so there comes to the case where is it really specific? Does it have to be specific? Or can it be just a general aspect of neurophysiological standpoint of doing an area below or an area above to get the same results?
Just to add additional context to that, when you said C7, my mind immediately went to the CT junction because
Yep.
that's an area that everyone, I think, recognizes as a common problem spot. But I'll be honest, when I do that manip, it doesn't matter if they're prone and I'm doing like a break kind of style, or if they're seated and I'm doing kind of like a scoop distraction kind of thing there. There is way more than one cavitation that occurs.
Yeah.
And they hear it. I hear it and feel it. There's not just one level going with that, even though it's supposed to be specific to this one level. So it's like, we might be trying to aim with the precision of a sniper rifle, but in reality, it seems like the result we're getting is more like a shotgun blast, if you will.
Yep. Yep, that's exactly true. You've got everything. If you think about the way the spine moves, you move one segment, the one above it, the one below it also has to move in opposite directions. Especially in the CT junction, you move the spinal segment one way, you're also affecting the ribs, right? You're moving the ribs, could be moving a little bit of the shoulder scapula, although there's no joint there, of course, but you're moving that whole complex. And that's why we need to start thinking of the manipulation model into more of a complex kind of more regional region versus a specific region.
Right, 100%. And I think this is an area too where you really need to have a large array of tools in your toolbox, right? You can't just know one way to do things, right? I mentioned two different ways that I do the CT junction manip. There's some people that I just cannot get them from a seated position with the CT junction, and I have to put them face down and get them prone, and I can
Yeah.
get them prone. But if I didn't have that skill, then I'd be like, well, sorry, I can't do it. I guess we're going to have to find you a different provider. I think having multiple ways to accomplish the same thing when it comes to spinal manipulation is absolutely essential. And even the T-spine, for example, I know pretty much everyone is familiar with that kind of famous like Texas twist or the prone variation that way. But I think it's also valuable to have them, supine. Or,
Yeah.
I mean, you could do the little seated one if you want, a little scoop. Personally, not a big fan of it. But again, there is a time and a place for everything. Maybe you don't have a table and you got to get it done. Well, guess what? Standing scoop thoracic works just fine. But I think in general, you need to have a large array of tools in your toolbox, multiple different ways to accomplish the same task because everyone's body is built a little bit different, structured a little bit different. And what might work for you onto one patient might not work for the next patient.
And that's where the whole aspect of provider experience, patient comfortability, you have to take both of those into account. When I see a patient, they've had previous manipulation history, I ask them, okay, what did you do? What kind of manipulation did you receive? Was it comfortable? Did you like it? Did you hate it? If they hated it, then of course we try to go a different position and to get that manipulation. So kind of both of those things integrated into each other will deliver the best result.
Yeah, I think that's a really smart way to do it that way. Now, walk me through like if you're going to go about doing spine manipulation and you're going to work your way through the entire spinal column that way, right? Where do you start? Do you start top down? Do you go bottom up? How do you kind of think about it from like a structuring intervention plan that way, if you will?
Everyone has their own preference, and where to start, how to do it, and what order to do it in. The way I'd like to do it personally is, I like to personally take out and clear out the CT junction. I like to because there's always a lot of kinks and junk that happens in that area because you think about the transitional segments, the different motions the cervical and thoracic spine have, all that kind of stuff. you get a lot of buildup of just tension and all that going on in there. So that's what I like to clear out first. And then I typically work my way down the thoracic spine. And then my next big area is going to be the TL junction. Again, a very, very big area where there's a lot of stuff that's happening because of the transitional segments. And then from there, I like to put my patient in some side posture and just get some movement into both sides of the lumbar spine, sacroiliac area. And then lastly, we finish out going, supine, usually getting clearing the cervical spine at the top.
That's awesome. Yeah, I like that flow a lot. Now I've got to ask a million questions. When you get to that lumbar region, do you go, typical Chicago roll or reverse air hard, or do you kind of lean more towards the newer lumbar roll that I see a lot of people doing?
Definitely kind of transitioning into more of a lumbar roll. I've seen better results personally when we don't do that Texas twist like you were mentioning, just because it puts the patient in a lot of torque and a lot of tension. And so sometimes it's good for the patient, especially when you can't get that TL junction. That's a good way to kind of get that torque rotation up until that T12 area, and then doing a thrust that way. But generally, I like to keep that spine in about as neutral as I can and just rotating the pelvis just a little bit. So more of a lumbar roll approach.
Yeah, and it sounds like you don't bias the flexion or the extension on that too much. You kind of keep it as neutral as you can and then roll from there.
Correct. Yeah.
That's interesting because I see some debate over that, and I'm kind of like you. I just kind of go right for the middle ground.
Mhm.
The other thing that I've done in the past, and I'm interested to hear your thoughts on this, is typically with the majority of my athletes, my forearm kind of goes through what I call the slot, so to speak, which is kind of that part of their pelvis, where my hand is able to get to their lower back and then kind of pull away. But I've also done some stuff before where I'll kind of put my leg on top of their thigh, their femur, as it's hanging off the table, and I'll just drop down real quick as a way to kind of generate more torque. And I've kind of been torn on that because it works really, really well for the right person. However, I've also kind of realized that in order to do that, I'm basically going through the hip joint to get to the lumbar spine, which, they might have plenty of hip mobility, or, they might not need any kind of force or be able to withstand any kind of force through the hip that way. So does that kind of longer lever technique sit well to you? Is it a tool in the toolbox, or is that something we should probably just steer clear of?
I personally like to use the femur as a lever to kind of help my technique a little bit. I feel like with doing your femur to the patient's femur, you get a little bit more control
Mhm.
of the patient's body. When you're doing the forearm, pulling the forearm towards you and having it on the pelvis, I've seen that sometimes I may lose control or contact of the patient. Now, the whole point of doing a manipulation is trying to get them in a kind of closed pack position as possible. And so if they're wobbly by not putting pressure on the femur and kind of locking that area, you may lose the kind of area you're trying to go, and therefore you may get a little bit of hip issue there, hip rotational thrust there. So I personally like to kind of lock the femur with my femur and put that in place, and then really try to generate my force over the sacrolumbar area.
Yeah, I like that. I like that a lot. And then earlier you mentioned the thoracolumbar junction as well, and that is definitely a problem area for a lot of people. But I've noticed a lot of clinicians struggle to manip that area, and it's kind of difficult to get, right? Because as you mentioned, it's transitional area. You might not be able to get it on a straight P to A sort of thing that way. So what's your kind of go-to approach for kind of getting that kind of difficult TL junction area?
So the best hack that we've been taught to do TL area is try to get them in as much flexion as possible, right? You want to really now obviously the lumbar spine has the lordotic curve, and so you want to try to really hard to do it, but try to get that lumbar spine into flexion. So what we usually do is when doing a P to A, you bring the knees up and you get the knees bent, and
Right.
then you have the patient wrap their hands around their head, and then you create a traction from the scapula, bringing that scapula elevated. So that'll create that traction upwards. And then you can get your hand contact under the TL junction, and you do a straight thrust P to A. Now, a lot of times some people have very, very tough TL junctions, and it's very impossible or almost uncomfortable for the patient to receive that manipulation. So that's when I kind of do that rotary Texas roll, right? So what I usually do is I put them in side posture and I swing that top leg off the table. So it's not bent or tucked in behind their other leg. It's off the table, fully extended. The knee is extended, the hip is all the way flexed, and you roll the lumbar spine until you kind of lock out that TL junction. You can palpate when that rotation happens a little bit in that L1 T12 area. And then once you kind of start feeling that L1 T12 move a little bit, boom, you can do your thrust, and you can really get that TL junction to move.
Do you have any issues when someone's got like radicular symptoms in the lower leg or neural tension or that sort of thing, getting them in that position at all?
Sometimes, but then again, we will follow the guidelines, right? That's also a very big, important thing to note is if they're having ridiculous symptoms, past the knee, they're not indicated for an adjustment. It's been shown that adjustments or sorry, manipulations aren't going to be that effective, right? So that's one of the things that we have to look for is making sure that the radicular issues is not past the knee, the way we can effectively provide the best results. But usually if it's above the knee, no issue at all too much, especially if that knee is a little bent.
Right. No, that makes a lot of sense. And it bring up an interesting concept with the neural input as well that way, because I think the way I've seen the profession shift, there's this obsession with test and retest methods now.
Mhm.
I do the manipulation and then I retest something that I tested before that way. Do you have anything that you like to test and retest before and after manipulation for neck, lumbar, thoracic junctions, that sort of thing. That way, is there anything that you're like, hey, look, when I see improvement with this, I know I'm doing something?
Yeah, I usually like to pick something that the patient describes in their history. That way I can make it patient specific, patient goal oriented. Let's say they have trouble looking in the rear view mirror, and I tell them, okay, before we do this adjustment, let's go through all the ranges of motion. Let's see how you're feeling. But then specifically, let's go into that rear view mirror position to see when you're feeling it, how you're feeling it, if there's a ridiculous symptom. And then we would do the manipulation, and then we would do it again to see if there's any centralization of that pain, if there's more range of motion of that pain, or just a general decrease in pain rating scale. So when it comes to that, I try to make it as patient centered as possible, just to let them know that the manipulation is a comfortable thing. It can work, but it's also important again to follow up with some exercises in rehab. And so that kind of is where I have my specific view on manipulation, versus the rest of the chiropractic world is we really have to make sure that when we have that window of decreased pain, that we follow up immediately with some stretches, some rehab, some exercises, because otherwise you're really not going to stabilize the joint. You're not going to make a long-term change. You're just going to have to keep coming back to you for pain relief, and that's not healthcare.
Yeah, we're trying to shift away from that dependency model as
Yep.
much as possible that way. And I think the other piece too that I'll do a decent bit that way is if I'm going to do a manip on someone, whatever I just improved, thoracic extension or lumbar movement, whatever it is that way, I'm going to give them something at home that does the exact same thing in exercise form. So, maybe it is thoracic extension and I'm going to give them, very similar types of movements, right? It could be as simple as they're going to sit in a sturdy back chair, they're going to cross their arms and they're going to lean back into it and just do seated thoracic extension over and over and over again. Is it the perfect exercise? Maybe not, but are they going to do it? Absolutely. So I'll count that as a win any single day. I certainly echo your point on getting people to realize that they can actually kind of take charge of their own situation and do something similar at home that way on their own. Now, I know you mentioned earlier that you've got a ton of experience in the athletic population that way. I'm curious, what kind of pathologies or issues did you see amongst the athletes that you were working with, whether that be basketball, lacrosse, and so on that way? And where did manipulation kind of fit into that framework, if you will?
When it comes to manipulation in the athletic field, if I'm being honest, it's not too much of is manipulation indicated, right? Many times, like we discussed earlier, it's just because the athlete wants the manipulation, right? They feel like their back is stiff, or their neck is feeling a little tight, or they woke up with a kink, with that acute wry neck. And so that's when we do a manipulation. And so a lot of times we actually do, because of the basketball population we work with, we see a lot of lower extremity issues. And then lacrosse, a lot of shoulder, elbow, wrist, hand, maybe some hip stuff when they're getting jammed. And so that's when a little bit of extra spinal manipulation, getting that joint movement, is also very, very important. And so what we see is going back to the concept of what is a manipulation actually doing. Regional interdependence, we've hit it all. And so doing manipulations in one area can decrease pain in a different area. So that's one of the reasons why I personally like to do a full spine manipulation, even if their elbow or the wrist is aching a little bit, because studies have shown that you can reduce issues and spasms a little bit, to a certain extent, with a spinal manipulation in different areas of the body. So
Yeah, no, I think that's a great point. And it's interesting too, because to your point on, manipulation one place can impact other regions. I've seen clinical prediction rules, and I'm not sure how good all of them are, but they're coming out with CPRs for spine manipulation for freaking knee pain.
yeah.
I see a lot of athletes with knee pain. So it's like, hey, should I be doing this for them? Is there a correlation there? Is it even, I hate to use this term, but a lot of patients, especially those that come in requesting it, they feel it's going to work. So I think there is a certain element for certain people that could be related to a placebo effect. But that's not to say don't do the intervention. It's to say just understand that, you might not be doing what you think you're doing, but you're getting the outcome that you're after.
There was just a study that I read the other day with individuals with lateral epicondylalgia, and they were put into different groups. One received, nothing, of course, control group. One received just cervical manipulations, and one received cervical manipulations with the lateral glide of the forearm. And it's cool enough because the cervical manipulation group only did receive benefits. It was significant benefits. Now, was it as good of benefits as the group with cervical manipulation and lateral glides of the elbow and exercises? No, of course they received the best benefits, but there was still a little bit of improvement seen at the elbow with only a cervical manipulation.
Now, my current theory behind that, because I've been trying to wrap my head around this for quite some time, and my theory is it goes back to all the things that in school I kind of glossed over and said, oh, I don't need to know that. I'm going to work with athletes.
Yeah.
The nervous system, it's really freaking complicated and it doesn't get any easier. And, I don't necessarily think we have it fully understood, but in general, if I do something at the spine, specifically the neck or the lumbar spine. And those nerves innervate the muscles of either my leg or my arm, then I'm having some kind of ripple effect downstream to everything from that nerve pathway that way. So I don't necessarily have it all figured out, but my theory is us acting centrally is having a domino effect to the periphery through something that has to do with the nerve root levels that way.
Yeah, and you know what? You basically hit half of the subluxation theory right on the nail. The idea is when we adjust this, when we manipulate a specific segment, we free up the nerve restriction, and the nerve is able to fully function down to whatever it's innervating. And so there is truth to that. Like I said, we see it in the study with lateral epicondylalgia. There is truth to it. But what is, like I said earlier, what's most important is we follow up with other exercise and rehab. Now, the mechanics of why that happens and how that happens, you said it again. It's still, everyone's still kind of wrapping their brain around it. What happens at the brain? What happens at the nervous system level after manipulation? I think the biggest thing that we know is, like I mentioned earlier, is manipulation will change the sensory inputs, then therefore change the outputs. And so that's the big picture of what's happening. But there are studies out there showing that you are changing, the brain structure, and so the way that motor outputs go out after manipulation. So there's a lot of different theories out there, but I don't think any of them have been solidified.
in relation to that concept of inputs and outputs for a second, how much input becomes too much for the system to handle? Because I bring that up because I see some individuals out there that'll manip and then they'll scrape and they'll cup and they'll massage gun or needle and they'll end up doing about 5 or 6 different manual techniques to one specific region in the same session. And I personally would have a very difficult time determining what the driver is behind the improvement that we see when we're throwing so many different things at it. And I'd also be, bold enough to say that if you do too much input, you're actually not going to get an output. It kind of takes time for the system to process all the stimuli that you just applied to it. And I'll go as far to say if you're just throwing random stuff at the wall, hoping something sticks, you probably missed something in your examination and evaluation that way. But, is there ever a time to overlap manipulation with other techniques that way? They're still hands-on in nature. And if so, how do you go about structuring that from your treatment standpoint? Do you do the other stuff first? Do you do it later on? What does it kind of look like from your eyes?
It's kind of funny because you described first 2 or 3 years of my practice where I would do a manipulation. I would do scraping. I would do, neck traction. I would do follow up and ending with stim and heat. And so I think going back to your question is figuring out why we're doing it. And it's important to look at, the clinical prediction rules and read the research that's been done before us, what works best. But I think what takes precedent over that is your patient response. Um, I believe if you do 1 or 2 things and you see the patient isn't improving, maybe try a different route. Maybe give it a little bit of time because some individuals take a lot more time to heal versus others. Maybe try a whole different approach. Maybe try stepping away from manipulation. Sometimes that works as well. And trying more stabilization or maybe just getting general joint movement. So, and trying to track patient response, I think, is the best way to figure out what works, what doesn't work, and how much should I do.
Yeah, I think that's a great point because ultimately we're all in the business of getting outcomes. And unfortunately, it doesn't matter how nice of a person you are. If you aren't getting people better, people are not going to want to come and see you in office. They
Yeah.
really want to get better. They want to get out of pain. They want to move and achieve whatever goals they've set that way. So the better and more effective you are at helping them, the busier your clinic is going to be because you're going to have people all over the place trying to get better because you are the guy for it. But also, again, where we started the conversation, I think if you're good with your hands, you're able to assess things and intervene with things a little bit better. And you're able to get the results that maybe other people could get, but you're able to get there faster, right? You even mentioned it when you referenced the study that you read recently, that manual therapy group plus exercise group got better outcomes than either one alone. So
Mhm.
the more powerful and impactful I am at doing both, the better my patients are going to do.
Yep. Yep. Exactly.
Have you had any resources that you've liked to reference or lean on in order to learn more about manipulation that way? Or obviously you've gone through the chiropractic schooling, so you've got a pretty good hands up on most people that way, I would say.
Yeah, I think staying up to date with the most current research is the most, and I kind of heavily go along the lines of JOSPT. They talk quite a bit about mobilizations and manipulations, and we have to go back to the fact that we can get similar, if not almost sometimes better results with doing mobilizations versus manipulations, right? So, it's been shown that mobilizations can provide, just a similar effect. And so they talk a lot about mobilizations, manipulations, and its correlation to pain is another one. There are a few TED Talks out there that talk about pain science, which is super intriguing. Like we talked about earlier, it's still a world that is still being researched and studied. But understanding the mechanisms of what's happening after a manipulation is really intriguing, as well as just kind of going around and finding individuals that have proven to show that they are backed by research. I think the biggest thing that we could do now is follow the research, follow, the studies, and go along the lines of what they've done to set precedent of what works and what doesn't work.
I always encourage people to look at the research, but also look closely.
Yeah.
Actually read the whole thing. Don't just skim the abstract real quick and jump to the conclusion. I've done it before. And it always gets me into a lot of trouble because the methods will tell you so much about if that study is actually worth it or not. So much so that sometimes I'll just jump right to the methods section, read through that, ask myself, does this make sense? And if not, or if it seems like they're trying to skew it a certain direction, maybe there's a conflict of interest there. I don't know. I just really like to take things with a grain of salt before I just kind of like jump to the conclusion, accept, and move on to the next one because I've made that mistake in the past. It's very easy to do. I would also say that in addition to reading the research, don't neglect the power of your own clinical practice. I look at each patient as their own case study. I'm probably in the minority group of physical therapists that still does this, but I actually still measure range of motion with a goniometer. I actually still give my laptop to the patients and have them fill out their own outcome measures and that sort of thing. I know it's not necessarily the standard anymore, unfortunately, but I think if you want to be effective as a clinician, especially from your hands-on standpoint, looking at your patients as their own case study and looking at them kind of like you would a research project makes you so much more effective in your ability to assess the data that you're collecting, the patient feedback subjectively, and actually put it into something that's meaningful and powerful and impactful that way, and then you kind of develop this own collection of dozens, hundreds of case studies of patients that you've worked with similar things over the timeline, and you've seen what works and what doesn't work from your own hands because research is a great guide, but unfortunately, it doesn't necessarily apply to how you as a clinician practice all the time, period.
Yeah.
Obviously, we all have different approaches to things. We have different approaches to our exercise selection, even manual therapy. Again, like we talked about earlier, there's a million ways to skin a cat here. So the way I do manipulation might be different than you, and it might be different than someone else, like say Greg or something like that, right? We all do it different. It might all give us outcomes and results, but we can't draw conclusions based on my technique versus your technique because they're very different, right? Like you mentioned before, we might not even be palpating the same spinal segment. So I think ultimately, the more you can kind of empower your own clinical skills and look at each patient like their own case study and ask yourself constantly, what can I learn and what is this person trying to teach me through working with them? I also want to bring up the extremity manipulation real quick because I mentioned that earlier. What's your thoughts on manipulating the extremities? I mean, knees, ankles, elbows, that sort of thing that way. Is that something that you do a lot in clinical practice? Do you see a place for that? And do you think that's something that clinicians need in their toolbox, or is it kind of a nice to know, not a need to know?
Yeah, I think it's nice to know. I think there are a few places that it's good to have the need to know it. I think the foot and ankle region is a very, very important area to know manipulations, just because it's such a solid structure with all the ligaments, all the tendons, all the osseous structures that are there. And sometimes doing a joint mobilizations in that area is going to be very tough, especially if you've had someone that has had chronic ankle sprains or any kind of injury that's been repetitive and they've built up all that chronic stiffness in that area. So I think the foot and ankle is one of my most important kind of need to know areas. Everyone walks on their feet every day. So that's a good area to know. But then also going back to individuals that have certain conditions to know those manipulations. It's also important that I say, if you have someone that comes in with carpal tunnel, and you don't necessarily know how to do a carpal manipulation, I wouldn't suggest you go in and Google it and YouTube it and then come back to the patient. Just because, like I said before, there is provider experience that's necessary. If you're not comfortable with it, the patient is also going to sense that. And sometimes, not sometimes, you can definitely injure a patient or make patients worse with manipulations you're not comfortable with.
I think that makes a lot of sense. You definitely need to be comfortable with the skill that you have that way. And I think that's where it's essential to, go to workshops, get hands-on experience that way, and get feedback from people that have been doing it for a long time with great success. And, they've kind of studied and learned under other people and kind of put their time in as well that way. I think it really pays dividends to put your time in and get highly, highly skilled at these things that way. Now, I know that you're involved in the spinal manipulation education world that way. So tell me a little bit more about the work that you do in that space, helping clinicians kind of refine their spine manipulation skills, if you will.
Yeah, so I've kind of partnered up with the physio lab, Dr. Eric Jordy, up there close to you. And we kind of try to go around and teach PTs, students, even if they're interested, how to perfect their spinal manipulation. Now, it's important that I note and preface saying that with our course, you're not going to learn everything perfectly within the first weekend. It's going to take time. It's going to take practice, just like anything else, to be confident and to be efficient with a spinal manipulation. So, but we basically go through a whole series of the most popular areas that need to be manipulated, CT junction, basically the entire spine is what we run through. And we show different techniques, different positions, different ways that to basically manipulate those different areas. Showing provider biomechanics as well. That's also very, very important, making sure the provider is in a good position, because if you get really good at manipulations, but your provider biomechanics aren't that well, you are going to, cause some wear and tear. So that's also a very, very big, important point that we like to touch on. And so, with the physio lab, we provide continuing education. We go around and we try to teach how to perfect all these manipulation techniques.
You bring up such an interesting point with the reference of the provider biomechanics, because there's been some clinicians I've seen that are just masterful at it, and they look to be about 50 plus pounds lighter than me and about 8 inches shorter than me, and they're able to manip people twice my size with
Yep.
ease. And then there's other people who are larger than me, manipping people that are significantly smaller than me, and they struggle. And I
Mhm.
think ultimately, at the end of the day, it's not just about brute force. As you mentioned before, it's about setup, it's about positioning of the patient, but it's also how you position yourself to create the most leverage, right? We mentioned the long lever technique for the lumbar roll earlier, right? Like that position could give you the ability to generate a lot more rotational force as opposed to just driving through your hand potentially that way. So I think that that piece on body position and setup of the practitioner is just as important, if not more important, than the setup of the patient.
Yeah, 100% agree. I always like to mention that one of the best chiropractic, adjusters that I know, I think she's like 4'10". But she knows how to handle any general population up to football NFL linebackers, and I've seen it before. So it's very important how to set it up, how to use your body as an advantage, whether if you're big or small.
I love that. I love that. Pratik, for people who want to find out more about you, or maybe they want to check out the Physio Lab and all of those courses that you have coming up, where can they find you at?
Yeah, so you can go to our website. It's going to be the-physio-lab-ceu.com. You'll be able to see all of our course dates. You'll be able to see a little bit about us as the instructors. You'll be able to see what we do, what we teach on. And pretty soon we're going to be coming out with a few more locations coming up soon. So I think we've got Delaware coming up in a month or so, a month and a half. And then we've got a Dallas date coming up in the summer as well. So those would be exciting times. We're going to have some more roll out. So be sure to check it out to see when we're coming next year state. And if you have a recommendation or you want us to come to you, then, shoot us an email. Our contact is on that website as well.
That's awesome. We'll link to all of that in the description below too. That way, if you didn't quite catch it, you can just click there and see everything that Pratik, Eric, and the entire crew at Physio Lab are up to that way, man. This was awesome. I really appreciate your time and all your insights that you shared with us today, Pratik.
No, I appreciate you having me on. Thank you.